There's been substantial discussion about statin intolerance. What is it? Does it exist? Well, statin intolerance is the inability to tolerate statins. Either inability to tolerate statins at the maximum dose, the high-intensity statin therapy, which is an evidence-based treatment for people with coronary disease, or partial statin intolerance, the inability to tolerate high dose but to tolerate a lower dose of statin therapy. We know from randomized clinical trials in patients with myocardial infarction or acute coronary syndromes that high-intensity statins is superior to low-intensity statin therapy. We had the opportunity to evaluate individuals in the Medicare population, older individuals 65 to 74 years of age, who had a myocardial infarction and had insurance coverage for their statins. We looked at individuals who had prescriptions documented for 1 year before the index event and then followed them for 2 years after the index event. We defined statin intolerance in a very strict way. The inability to tolerate 3 statins in a year, the inability to tolerate a statin through, as defined by a reduction in the dosage plus the addition of ezetimibe, or a reduction in the dose of the statin. And using this definition, there were about 2% of individuals who were defined as having statin intolerance. We did not include individuals who discontinued the therapy because there could be many reasons why people stopped the statins. As an example, a change in the provider, the cost of the medications. So we just focused on this very strict definition. Then we really didn't get into the debate about whether statin intolerance exists or it doesn't exist. We just asked what happens to these individuals who have had a myocardial infarction that are on a reduced dose of statin or a reduced dose of statin plus ezetimibe. And in the 2 years following their index event, their myocardial infarction, they had more recurrent myocardial infarctions. They were more likely to have more cardiovascular events, myocardial infarction, stroke, the need for revascularizations, and they ended up in the hospital more frequently. So our analysis isn't challenging some of the definitions, some of the concerns that have been discussed by some of the clinical trialists. It really addresses the issue about the fate. And we know that people that can't tolerate maximum dose of statins are more susceptible to cardiovascular events, and the excess burden of more procedures, more hospitalizations, is costing our society a substantial amount of money. When we think about options other than statins for lowering LDL cholesterol, we need to take into account not just the cost of the medication, but what is the cost per event avoided. And this is why I think that our analysis would be particularly important.